CDK4/6 inhibitors are broadly used in the most common population of patients in the metastatic breast cancer setting. So, in a patient who has hormone receptor positive metastatic breast cancer, essentially in the United States, all patients will be exposed to CDK4/6 inhibitors with rare exceptions. So, this is a very large population of patients, and the drugs have been widely adopted due to their general tolerability and huge success, showing marked improvements in progression-free survival and in some cases overall survival. So this is a perfect situation to try and uncover toxicities which had not been seen even in numerous phase 3 randomized trials, because as you start expanding the number of patients receiving the drugs who haven't been screened for clinical trials where you really treat a specific group of patients who are particularly well, you won't see those toxicities. So really the way we first found that CDK4/6 inhibitors could cause interstitial lung disease is in trials that were expanding the use of the drugs and treating patients in the later line setting. And it also may be, and this is interesting because it's not just for the CDK4/6 inhibitors, but other agents, including ADCs, there may be differential risk, as I mentioned, based on pharmacogenomics. And what that would do is mean that geographically and based on ethnicity and race, there may be differences in terms of risk, because where we first saw these risks were in the Asian population in Japan, where it really was highlighted, Japan and Korea. The bottom line is that although this was highlighted and there was an initial number of patients with a single CDK4/6 inhibitors, on really delving into the safety databases, it was discovered that all of the CDK4/6 inhibitors can cause ILD. The rates are extremely low, and the severity is generally low as well. So I actually haven't seen anything that was clinically significant in terms of ILD with CDK4/6 inhibitors. I think that if you see pulmonary changes on scans or a patient has symptoms, you have to keep this in mind, but it is really extraordinarily uncommon. You would not want to treat a patient through pulmonary symptoms, since these drugs have short half-lives, unlike the ADCs. You know, if your patient came in with pulmonary symptoms, you definitely want to have a low threshold for getting a chest x-ray and for holding drug and evaluating whether or not this could potentially be a drug-related effect. In terms of what we do you discontinue or dose adjust? If a patient has symptomatic ILD or a question of this, you should discontinue whatever the offending agent is. For CDK4/6 inhibitors, because of the short half-life, this is a little bit easier than some of the other drugs. Would you then restart the agent? Well, I think this really brings us back to our experiences with everolimus, where if patients had very mild ILD, we would restart at usually at a dose reduction. So you would adjust the dose. But then you watch a patient very closely, and in my experience, patients who had the classic ILD from everolimus, if it was symptomatic, patients were short of breath and they had radiographic changes, it was difficult to have them tolerate the drug. This is just their susceptibility, and they would get the symptom again. Again, because the risk with CDK4/6 inhibitors is so incredibly low, I don't think we have the experience to understand what the risks are with restarting. Anybody who has a symptomatic ILD with hypoxia of grade 3 or greater, I don't think we should be restarting the offending agent in general, regardless of the situation. Identifying ILD can really be a challenge. When patients, I tell my patients, if you have a cough or shortness of breath, of course, let us know right away. Don't wait for your next visit, which is often something that patients will do, which is to the detriment of the management of the toxicity. So the most common sign that a patient would present with or symptom would be a cough. And the most common sign and or shortness of breath, the most common sign would be interstitial changes on the CT scan. So actually now, and I have found that with COVID-19, we are seeing interstitial changes on almost everybody's CT scans. Anybody who has lung involvement from their malignancy or had prior changes may have sort of ever-changing interstitial findings on CT. So I actually review the actual images often with the patient, which we can do even in telemedicine visits now. But I do review it. And if a patient's had radiation, for example, previously, I discuss it with my radiation oncologist. If I have questions or concerns, I would ask my pulmonary colleague to review the film and tell me what they think it looks like. And this is actually very, very helpful. We haven't seen other clinical manifestations other than cough, shortness of breath, and sometimes people will have tightness in their chest as a particular symptom associated with ILD. And those are the real symptoms to look for. I think that what I would recommend and also highlight is that if a patient comes in with a respiratory symptom, it should be evaluated right away, even if you're fairly certain that it's related to their pleural effusion, or they already had lung disease related to their cancer, or they have, for example, some benign cause of cough and shortness of breath, such as asthma. I think that you really do need to make sure that you've had imaging and an evaluation at least one time for a specific symptom. And it is really important that staff and patients be educated about calling in and letting the team know if they're having specific symptoms. I think that one of the things that helps a lot in clinical practice is understanding the time frame for developing the ILD. Mostly, we think about diarrhea, low blood counts, even mouth sores or rash occurring relatively early after exposure to a drug. But ILD is something that can occur over a fairly long period of time. So I think one of the really important messages is not to let your guard down. So when a patient does have a symptom, just think, okay, are they on a drug that could cause ILD? And what should I do to evaluate this given the symptoms that a patient is expressing? Usually what's interesting about ILD and pneumonitis is that there aren't exam findings other than noticing that somebody has a higher respiratory rate or hypoxia in the more and higher grade situation, which you definitely want to avoid. Diagnosing people as grade 3 ILD, you want to find it at grade 2 or grade 1. But I think that understanding that this can occur over a long period of time, so that when patients call in with these symptoms, they should be evaluated right away. And it's also, I think, important for staff and patients to understand that if they have symptoms that where you're suspicious that it might be ILD, to stop drug first. And then you can always restart. It's just much better not to treat a patient who has emerging symptoms, because you may have a situation which is much more difficult to treat and reverse. Well, I think that your end point for the cancer is going to be the same, but you can't start new treatments until you manage the pulmonary issue if a patient develops significant ILD. So I will, clarify that if a patient develops ILD and it's grade 1, you may need to discontinue the drug depending on the guidelines for that specific agent, because the risk of having a higher grade and more symptomatic or potentially life-threatening ILD has been identified. This isn't true for all agents that cause ILD, so you need to be familiar with those particular guidelines. For example, discontinuing drug and treating for patients who have grade 1 ILD for trastuzumab deruxtecan, but we don't necessarily do that for everolimus or CDK4/6 inhibitors, because the transition to higher grade ILD is much lower. So if you see a little change on CT and the patient is completely asymptomatic, you just need to monitor it. So there are different treatment goals for the cancer depending on the agent. And I think that, what you want to do is immediately identify and manage the ILD so that you can start new treatment for the patient if you need to discontinue the causative agent, so that you can really maintain the same treatment goals for the cancer.